Welcome to our November seminar as part of the Prevention Research Center for Healthy Neighborhoods seminar series. Before we get started, just a few logistics and housekeeping for today's seminar. We recognize that in this format, you can't see who all is on the call today. If you could please use the chat feature to write down your name and organization to let others know who is here and joining the presentation. We'd greatly appreciate that. For questions, we ask that you please use the Q&A feature. Also, there is a raise your hand feature, which you can use during the question and answer periods if you'd like to request that your microphone be unmuted. We're excited to have Dr. Shari Bolen joining us today to present on the formation, vision, mission, and early results of a Medicaid-funded statewide cardiovascular health collaborative, Cardi-OH, and Hypertension Quality Improvement Project. Dr. Bolen is an Associate Professor of Medicine and Population and Quantitative Health Sciences at Case Western Reserve University, Founding Director of the Population Health Research Institute at the Metro Health System, Director of the Case Western Reserve University Center for Healthcare Research and Policy at the Metro Health System, and a practicing general internal medicine physician. Dr. Bolen serves as the Director of Cardiovascular Disease Programs for Better Health Partnership, a regional health improvement collaborative, and co-leads the Ohio Cardiovascular and Diabetes Health Collaborative, funded by the Ohio Department of Medicaid. Nationally, she currently serves on the Department of Health and Human Services National Clinical Care Commission, charged with developing recommendations to Congress on addressing gaps in federal programs and policies for persons living with diabetes, and serves on the Centers for Disease Control and Prevention National Hypertension Roundtable. Her career is focused on evidence synthesis and implementation of evidence-based strategies and innovative programs to improve cardiovascular health outcomes with specific interest in diabetes, obesity, and hypertension. The primary goal is to improve the care of the patients and community she serves. I'd like to welcome Dr. Bolen with us today.
Thank you. Thanks for having me today. I'm just going to pull up. Let me know if you can see my slides. There we go. Can you see them okay?
Yes.
Okay. All right, great. So welcome. Thank you for that lovely and long introduction. And I'm really going to talk about our statewide cardiovascular collaborative, how it got started. It's with some of our regional activities and then led to that statewide approach. And just for some of you know me, but for those who don't, I'm happy to have discussion and questions. And so what I have asked Sarah and Brianna to help me with is to monitor the Q&A section, and they'll help interrupt if they think it's a good time to interrupt, but I will also stop at certain sections throughout the talk just to give a chance for people to answer some of those questions as we move through rather than listening to the entire presentation. So excited to have this discussion with all of you today. I have no disclosures or conflicts of interest. And my objectives really with this presentation are to discuss some of our regional activities, which led to the larger statewide approach, describe the formation, our vision, mission activities, and results of the early results of our statewide collaborative. I'll highlight some aspects of our aligned quality improvement projects that we're doing in primary care practices across the state and talk about some future directions. Great. So many of you probably know a lot of the background of health within the U.S. as well as our state, but I wanted to just give a little bit of background around this. So cardiovascular disease is a leading cause of death in Ohio. Ohio is in the top quartile of states for highest cardiovascular disease events. And you can see that with this map, which is from the Million Hearts map, which is done by the CDC. And they take some of the data on healthcare utilization and vital statistics, and they put it in. So this is looking at heart attacks or strokes that led to hospitalizations or deaths. and or emergency room visits. And you can see that darker colors means there were higher event rates, and that Ohio is in the highest quartile or the for number of events. So it's an area where we have a lot of room for improvement. Using the Health Policy Institute of Ohio's 2019 Health Value Dashboard, Ohio ranks 44 out of 50 states for adult smoking, 42 for life expectancy, 41 for adult obesity, and 40 for insufficient physical activity. So again, now this looks at the health on each of those metrics, as well as how much we spend in Ohio for healthcare spending. And so it's not just health outcomes, but also that in relation to our expenditures. So just, we are not doing, we have some clear opportunities for improvement there is really the main point. And this is a map from Robert Wood Johnson Foundation looking at Ohio and all of our counties, and just showing that out of our 88 counties, the ones in the darker color are the ones that have that rank the poorest in terms of health outcomes. And I think just the main point I'm making with this is really that there's worse health outcomes focused in the Appalachian and sort of urban areas. And so if you were going to focus in particular aspects of Ohio, those might be an area for important impact, and Cuyahoga County is one of those. So regional health improvement collaboratives have been one way that regions across the United States have brought together stakeholders to accelerate improvements and reduce disparities in health outcomes. And while health collaboratives in general vary in scope and their structure, they share certain common characteristics. They're often operating on a nonprofit basis. We have a core of credible stewards to assemble stakeholders within a geographic area, and they use data and stakeholder engagement to understand, plan, and facilitate improvement in healthcare. So many of you may have been on last month's seminar series where Better Health Partnership presented their community hub work. But I'm going to talk a little bit, for those of you who weren't, that's fine. I will try not to repeat anything. There's very little repetitive between the two. But I'm going to talk about some of the activities we did as part of that regional collaborative that led to a broader statewide spread. So Better Health Partnership is a regional health improvement collaborative. It publicly reports on quality of care metrics at the clinic level using electronic health record data from over 200 primary care clinics in over 10 health systems in Northeast Ohio. And we have quality metrics that are nationally endorsed and locally vetted, and we facilitate the identification of evidence-based best practices among high achievers within a network of primary care clinics with common goals and similar challenges. So I'm going to talk a little bit about how in Better Health Partnership we've used a positive deviance approach. And I'm going to explain what that is for those who haven't heard it before. But typically there's been this reported 17-year gap that exists from translating evidence from trials into clinical practice. And the Institute of Medicine report, Crossing the Quality Chasm, describes that. Now, whether you think it's 17 years or less, there is a gap, and it takes longer than we would like to get evidence that works into clinical care. And the positive deviance approach is really just one way to facilitate faster identification and dissemination of best practices into care. And it's really based on the observation that in every community or in every group, there's certain individuals or groups whose uncommon behaviors and strategies or outliers enable them to find better solutions to problems than their peers while having access to a similar number of resources and facing similar or worse challenges. And so I put this graph in here because often when we're putting data together and looking at what that tells us, we're looking at the average and we're trying to fit it into, this is what happens to this group of people. And we're trying to get rid of outliers and folks who show things that are different. So here the statistician is saying, outlier, your theory is wrong. In this case with positive deviance, we're actually looking at those outliers and saying, what are they doing to really improve outcomes? What are they doing that the other people aren't doing? And is there something we can spread to bring everybody up and raise that for everyone. Sorry, went backward. So the initial use of positive deviance was really developed by Dr. Jerry Sternin. He was a professor of nutrition at Tufts and director of the Save the Children program. And he was asked by Vietnam to create a program for childhood malnutrition in 1990. So this is going back a number of years. And he had 6 months to demonstrate that there would be an impact, and he had limited funding resources and needed a sustainable program. So Vietnam, the leaders there basically said, we're going to revoke your visa after 6 months if you don't show an impact. So this may remind you of many projects where we work on that seem like we have to do things really quickly to show improvements, and we often are underfunded to do that work. So I think that, and we're often trying to deal with really big problems. So I think that's a really big point for what they were able to accomplish. So they went to one of the poor districts there. They convened a group of stakeholders. They asked for volunteers. They weighed all the kids. They categorized them by income and conducted focus groups and observation. And they found that that almost all the poor families that had better nourished children were doing the 4 following things. They were washing their kids' hands a lot. They were collecting shrimp and crabs from the rice paddies and using that to feed their kids. And many families thought that was taboo or unhealthy for their children. They were feeding greens from sweet potato tops, feeding kids small amounts 4 to 6 times a day, so they got more nutrition throughout the day. And then they had a program of action that they instituted. So they had parent volunteers who had been doing this work to come for 2 weeks and work with them, and they showed them how to collect and prepare food. And then they repeated that practice in other villages, and they were able to reduce the malnutrition rate by 65 to 85% within 2 years. So really remarkable progress within a pretty short time frame. So Better Health Partnership was really taking this and trying to use this positive deviance example in a healthcare setting. So here, this just describes sort of that approach. We got electronic health record data from all of our primary care clinics, and then we used that to find the bright spots or people who are improving the most or doing the best. We interviewed the key informants at all those sites and documented what they did. We disseminated the process within a safe space, which at that time was our learning collaborative conferences that were twice a year. We remeasured to see if others had also improved. And if they had improved, we had another replicable evidence-based best practice. And this is showing how we identified the best practice initially. So we had for blood pressure control in particular. So each row was a unique Better Health Partnership member clinic in these graphs. And the blue rows indicate clinics which all belong to one health system. So we looked at that in 2011 and saw that folks here in this graph, you can see that all of the top clinics that had achieved the best blood pressure control were from that one health system. And in the second graph, you can see that even though there were some that had improved, other clinics from other health systems that had also improved, all of the clinics from that one health system were in sort of that top tier of clinics that had improved the most in blood pressure control. So we went to them and we asked them what they were doing. And they said that these 5 elements were things that they were working on. So one was accurate blood pressure measurement, including repeating blood pressure if that first blood pressure was high. The second was timely follow-up in monthly staff-led hypertension visits until the blood pressure was controlled. The third was a treatment algorithm that prioritized once daily, low-cost, effective blood pressure medications based on the Kaiser treatment algorithm. The fourth was outreach to patients with elevated blood pressure using that electronic health record-based hypertension registry. And then the fifth was a communication curriculum that was focused on patient-provider communication and having effective communication. And they actually did 3 days, a 3-day curriculum that we had modified into 3 one-hour sessions. And it was focused more on building trust, addressing implicit bias, and health literacy for our dissemination work. So for dissemination, we really employed 3 different dissemination arms. We had a high, moderate, and low intensity dissemination arm. Our high intensity arm did monthly quality improvement practice facilitation for 6 months and then quarterly for at least a year. We offered this to all low performing practices, which were in general the bottom third of the practices. And that was really just because of capacity issues. We didn't have a quality improvement facilitator that could work with all of the practices. And all of our low performing practices that we offered the service to accepted the service. We had not planned to do a moderate intensity arm, but we had several practices and systems that came to us wanting to be able to implement this within their health system and wanted additional information on how to do that. So we had consultations, and these were typically at least 2 or 3 one-hour sessions, and we shared our online resources and materials that they could use with practices to implement this within their own health system. So those were offered to those who had interest. And then we had a low intensity arm where any of our participating practices could participate in our learning collaborative conferences that were held during this time. And at many of those conferences, we had practices share what they were doing around the hypertension best practices and the work that they were performing. So they could have heard about it at any of those events. And these are our results from that. You can see for this graph, hopefully you can see my my white arrow here, but this just in this first section, it's looking at overall blood pressure control, and that was the percent of patients that had their blood pressure less than 140/90. And you can see that for years, we really didn't make any changes in blood pressure control, that we were around 66% of our patients, or 67 or 8% of our patients under good blood pressure control. In 2015 is where most of our implementation work occurred. And you can see that we improved our blood pressure control to having that be 75% of patients under good control. And I didn't update these graphics, but we've maintained that or slightly increased it since the 2017 timeframe. So we've been able to sustain that improvement. The other thing that's really important here is you can see that we almost completely eliminated the gap in blood pressure control between Medicaid and uninsured patients and the commercial and Medicare patients, although there is still some gap there at the end. And then by race ethnicity, we were almost able to completely eliminate the gap between Hispanic and white patients, although there's still a little bit there. We reduced the gap in blood pressure control between African American and white patients, but we did not completely eliminate that. And that's an area of focus for the future work we do. And then same with income and education, we reduced that gap in blood pressure control in those 2 groups as well. And this is just looking at our improvement by dissemination arm. And you can see that in our low intensity, where people could just attend the conferences, blood pressure control really didn't change at all. And then in the high intensity group, which is the green arm, that you can see that that group started with lower blood pressure control, because again, we were targeting those practices with worse blood pressure control, and they had the greatest improvements in blood pressure control. So really remarkable improvements of around 15 percentage points, which is fantastic. And then there's a moderate group that we started at a higher blood pressure control, but also improved and were able to maintain at similar rates to our high intensity intervention arm. So I'm going to stop there for just a minute before I move into this broader reach, just to see if there's any questions about this or comments about some of the work we did before we move into the statewide approach. And so if you have questions, I think you ask them in the question and answer, or you can raise your hand to unmute, right, Brianna or Sarah?
Yes, please use the Q&A box to type in your question, or if you'd like to have your microphone unmuted, please use the raise your hand feature.
I made it crystal clear. I'll give it a minute for people to ask something. And also, if people have questions that come to you as I'm going through, feel free to enter them in and we'll save them also, because I know sometimes it's hard to remember as we're going through if there's anything.
So we do have a question. Was it easy to get buy-in from health systems and clinics for the implementation, or what challenges did you have with that?
Great. Yeah, that's a great question. You know, because Better Health Partnership they already have a sort of leadership group. So all of the health systems have representatives on that committee. We actually went to that leadership committee first and asked them if that was an area of interest for them, which it was at the time, because in 2015, there was a lot around the ACO and accountable care organizations, and there's financial incentives that could be gained through improving blood pressure control, in addition to the fact that, you know, these were providers, primary care providers, and we deal with blood pressure control as sort of the bread and butter of what we do. And so there was a lot of interest from just the perspective of wanting to improve care. So that was probably first and foremost, but it's helpful to have the financial incentive piece for having administrators and leadership above the primary care provider level that are engaged in the work. So so being able to use the framework of having that leadership committee already involved and sort of supporting the work at each of the health systems probably made it much easier for us than if we were starting de novo without any of that background and framework. And they had blood pressure was one of the quality metrics we were following already as a group. So there's a lot of strong interest there already. So so that made it easier for us for this particular piece. We still did go to all of the individual systems and leadership to make sure they were engaged, as well as their primary care providers. So it was, we still had work to do in terms of meeting with the primary care teams and getting their engagement in the work. But I think people just felt like it was, you know, work that they wanted to be involved in. It's a really important area, and a lot of primary care providers want to do well in this for their patients. So.
And then, awesome, thank you.
Should we move on, or should I give it I'm not looking at the Q&A, so Sarah or Brianna, you tell me.
We currently don't have any other questions. If we do get any more in, I can let you know. Okay,
sounds good. I made it all, I'm feeling very good that I made it all crystal clear, or people are, you know, doing their emails at the same time. No, I'm just kidding. So looking at a broader reach for statewide cardiovascular collaborative and how that led to this. So I will say, so what happened, we were able to show these improvements, and right around the same time we were showing these improvements, Ohio Department of Medicaid came out with a request for applications to establish a statewide cardiovascular health collaborative. And they wanted to link several of the medical schools across Ohio because of the way the dollars came in. It was geared toward dissemination to primary care teams. And then they had us in the same RFA, or the same request for application, they also asked us to apply for the Hypertension Quality Improvement Project. So even though Medicaid actually funds these out of two separate streams of money, they actually put it in the same application. And so right when we were finishing this regional work, we saw this application, or this request for application, and just really matched the work we were doing and the ability to then spread this across the state. So we were really excited about that opportunity and put in a proposal from Case Western Reserve University School of Medicine. So Cardi-OH it was founded in 2017. The mission of Cardi-OH is to improve cardiovascular and now diabetes health outcomes and eliminate health disparities in Ohio's Medicaid population. It's an initiative of healthcare professionals across Ohio's 7 medical schools. So we've been able to, in the first year, we were funded, I think, with 4 linkages with 4 medical schools, and then we were able to expand that to all 7 in the second year. And we focus on identifying, producing, and disseminating evidence-based cardiovascular and diabetes best practices to primary care teams. We do that through a number of modalities. We have a monthly newsletter, an online repository of resources at cardio.org, which is our website. You're welcome to go there and see more. We have podcasts that we just started in the past year, and I'll talk more about our Project Echo virtual training model and annual statewide conferences that we are not doing this year, but have done in the past, and then webinars. So I'm not sure if folks on the call have heard of the collective impact model. I know many people use this as they're thinking about collaboratives. And this was part of what we thought about when we were establishing Cardio, our statewide collaborative. And I put this figure on here of the 5 elements of collective impact, and it has some of the areas that usually you want to see if you're doing a collective impact model. And collective impact model really was started to address very large social problems that needed more than just, a few people's opinions on how to fix. So it was these really large, complex issues that you need a group of stakeholders with diverse opinions to really try and address these really complex challenges. So that's how it really got started. And you can see that when you're bringing a large group of diverse stakeholders together, you want to have a common agenda or common understanding, and that's the first piece of that 5 key elements. And then you want to have a shared vision, so bringing everybody together around that shared vision. The second is shared measurement and thinking about how we collect data to measure our results or our success. There's also a focus on performance management and shared accountability, because often when you do, not always, but often when you do these collective impact models with multiple stakeholders, you may have different people submitting different data to try and have that shared measurement approach. The third is mutually reinforcing activities, where you have different approaches that sort of reach the same goal, or coordination or alignment of goals in different organizations. So you have greater impact by bringing together alignment in the different organizations. And then the fourth is continuous communication, where you have consistent and open communication focused on building trust among the different organizations. People do have different perspectives and priorities, and trying to meet everybody where they're at and where they can actually contribute. And then the fifth is having this backbone support, which in this case is the Case Western Reserve University School of Medicine, with sort of organizational structure and staff and resources to convene and coordinate the participating organizations. So I would say that Case School of Medicine is the primary backbone, but many of the other schools of medicine provide some areas around that as well. And typically, even though there's these 5 key elements, it typically has 4 phases, and those 4 phases often take 3 to 5 years to actually go through. And the first is around generating ideas and dialogue. How do we address these problems? What are we going to initiate action on? How are we going to organize ourselves for impact? And then the last is really sustaining action and impact over time. And I wanted to show this video primarily, I think it's a funny video, so I think you'll hopefully enjoy it and smile while you watch it. But I think it also, sometimes when you think about these collective impact models and all these diverse opinions, it can sometimes feel like herding cats. So that's why I show this video. But it, truthfully and seriously, I think that it's so important for all of us to talk together and share our viewpoints to get where we want to go. So let me just share this with you. We'll see if I can get it for all of you to hear it and work.
This man right here is my great-grandfather. He's the first cat herder in our family.
Herding cats. Don't let anybody tell you it's easy.
Anybody can herd cattle. Holding together 10,000 half-wild short hairs, well, that's another thing altogether.
Being a cat herder is probably about the toughest thing I think I've ever done.
I got this one this morning, right here, and if you look at his face, it's just ripped to shreds, you know?
You see the movies, you hear the stories, I'm living a dream. Not everyone can do what we do.
I wouldn't do nothing else.
It ain't an easy job, but when you bring a herd into town and you ain't lost a one of them, ain't a feeling like it in the world.
bring back up the slide. So hopefully some of you smiled a little bit, especially if you have cats at home. I do think that it's I joke around, but I do think it's really important that we're all working together. So these are our executive PIs for cardio for the collaborative, and you can see the different universities. Mike Constant serves with me at Case Western Reserve University, and we're co-leading the initiative from the School of Medicine. And Sarah is on our data and evaluation team. So you can see that these are our 6 amazing teams. We have data and evaluation, which does what it sounds like. They help us evaluate our program and have success metrics to follow. I'll talk about ECHO in a moment and what we do with that. Our team best practices helps develop materials for our website and what evidence-based best practices we want to share. And then we have an informatics and web team and a marketing communications team as we think about dissemination and getting things up on our website and communicating. And I'm currently a temporary lead of our advisory committee, but we've had some great leadership there as well. And these are our high-level success metrics for the collaborative, is really to have a diverse group engaged with our collaborative, and the number of and type of healthcare professionals in our different events is something that we follow. In particular, we need to track Medicaid providers, so people who are seeing Medicaid patients. We have success of educational events as a second success metric. How many people did we reach? Was there a knowledge increase? And then the third is a perceived uptake of best practices by participants in our educational events. And then our cardio activities, and I'm going to talk about some of our activities and early results. And so we do an annual needs assessment to identify learning gaps that we can provide for the next year, so that we're not just creating materials that we think are the right things, but actually are areas that have been sought out through our collaborative and where there's an actual need. We then develop and assess our resources. And we have many different learning events, as I mentioned. And we also we try and put together things in existing events as well, so that it's not only events that we're creating, but if there's a statewide conference, such as the Ohio Patient-Centered Primary Care Collaborative is doing a conference, we'll try and infuse material and content into existing conferences so that we reach more people. And then we're aligning with our Medicaid funded quality improvement projects, which I've mentioned. So just some early results. We have about 1,000+ people that we email materials to in our database. About 600 of those have engaged with one of our cardio activities. And we have 123 people that are actually paid on our collaborative grant across the state. For our needs assessment, we had 111 of those 123 folks respond to our initial needs assessment. And then you can see I'm just going to talk about a couple areas because I can't tell you everything in our needs assessment. That would just take the entire hour, but just a couple areas that I thought you might have interest. So the top 3 areas for topics were social determinants of health, lifestyle approaches for type 2 diabetes, and new and emerging therapies for type 2 diabetes were our top 3 topics of interest. And our needs assessment in the spring was focused around diabetes topics, because that is the paid focus of our grant for this year. 2 other things, we had the 3 most common reasons that were perceived for clinical inertia. And I don't know if any of you know what clinical inertia, but just so just to make sure everybody knows or is thinking about that the same way, that's when a provider does not intensify or start a medication in someone who might need it. So if somebody's blood sugar is very high, why was a medicine not started? And so the 3 most common reasons that were perceived by our group was a lack of patient understanding of the need for intensification or a medicine. The second is competing priorities at the visit. So there may be a lot of other things that are going on that need to be addressed. And then lack of patient motivation was a perception for why this wasn't done, that patients might not be motivated or interested in taking a medicine, which I think is really interesting that those were some of the top 3 reasons that that our group thinks about. I'm not sure that that's necessarily true, but it's interesting that so many people really thought that. The foremost common perceived barriers to team-based care, which is another area we're really trying to work on in primary care, was lack of reimbursement was a big issue. Lack of staff to be able to do that, which probably is related to the reimbursement issue, and then lack of institutional support to really put this in place, and lack of leadership. So even if all of those other things were involved, you need someone that really knows how to implement team-based care within a primary care setting. And then lastly, from that needs assessment that I'll talk about today, were the perceived areas that Medicaid managed care plans could better assist patients. And there were many of them, and I'll just read some of them, but transportation was an area, easier ways to get blood glucose monitors, so I apologize for some of the abbreviations, coverage of diabetes self-management education, coverage of diabetes prevention program, coverage of 90-day supply of medications. So I don't know if you knew this, but Medicaid was only covering 30-day supply of medicines until the coronavirus. Well, we had worked with plans to actually make a difference before coronavirus, but that switched and they were able to start doing 90-day for all of the payers at that point in time. And we're encouraging that to be maintained. And then standardized indications for continuous glucose monitoring coverage for those who need it. Covering community-led diabetes self-management education, and then patient navigation were all areas that were perceived as a need from the payer side that they could do to better assist their patients. And because the payers are involved in our collaborative and in the quality improvement project, I think it's really important that we share back with them the needs and areas that they can focus on. So I said I would talk a little bit about the Tele-Echo Clinic, and so I wanted to show you this clip of it. The Tele-Echo Clinic series is a way to expand primary care capacity to manage specific conditions. So what they do is you get primary care clinics from across the state to join virtually, and it's a series once a week for 12 weeks. Where it's an hour long, there's CME attached to it or continuing medical education for providers who attend. And it's not just providers, you can have nurses as well as other team members. So it's not specific to only prescribing providers, but people that are taking care of Medicaid patients. And it's focused on our most recent series is around diabetes and social determinants of health. And so they try and address issues around that. Our first series were hypertension and social determinants of health. And so initially there's a 10 or 15-minute didactic around a particular topic. And then we have a case that's presented. And then we have experts that serve to help answer questions. And so by having those experts there, the primary care teams are getting, more knowledge from these experts that over time they should be able to do this on their own without any expert consultation. So here is the clip from one of ours, just to give you a sense of what that looks like.
I mean, this was a 54-year-old woman who came to me to establish care in probably late July of 2018. Her primary concern was her knees. So she's a factory worker, lots of standing on cement floors. Her knees had begun to bother her, particularly the left. So she wanted to see me to talk really about arthritis. Her blood pressure, as you can see, she popped to 155/100, and then it calmed down. And then she came in a couple weeks ago, and I started her on therapy after her BP was 135/95 on repeat.
So at this point, we would stop, open it up to any questions for Kate about the patient.
This is Jackson Wright. Look, one question that I have, were her blood pressures measured manually in the office or by oscillometric?
Oscillometric.
Reason for asking is there's wide variability in the blood pressures.
Yeah, I agree.
Yeah.
I noticed that the guideline committee that Jackson was part of puts more emphasis upon out-of-office measurements as well.
I think the issue here is that this patient, essentially every blood pressure that has been measured is in the hypertensive range. Is it possible that she has white coat hypertension? And that's something that can only be ruled out by using out-of-office blood pressures.
Okay, so this clip really focuses a lot on the clinical piece, but gives you a sense of that back and forth that's happening, which is why I wanted to show that. But this, and they're talking a lot about whether the blood pressure needs out of office readings to determine if the person's blood pressure is really high and if they need to make any changes to the regimen. But I think, you know, we've had this conversation about social isolation and how that impacts health, as well as substance use. So there's, and then motivational interviewing. So there's just a lot of things that come up that allow us to learn from one another and share evidence-based best practices. This is our website. If you go to our website, you can see that we have different areas. We have the Cardio Echo where you can go and listen to some of the didactics. We have the best practices where you can see some of our resources. And when we have events like webinars and conferences, those are under there as well. And so from best practices, or actually before I get to best practice, from the website resources, this just gives you a sense of the different topics. We have hypertension management, lifestyle management, social determinants of health, patient adherence. And we use the term adherence for our website because many primary care teams use the word adherence. So if they're searching for something, that is how they would look at it. But we also recognize that, that it's not, you know, whether you adhere to a regimen is often influenced by many other things outside of the patient's control. And so there is terms more like medication taking and some of the barriers to that that are used more in terminology today, as opposed to using these terms like compliance or adherence. But we do, so I do want to just point that out, that we are aware of sort of some of the language pieces, but I think still important for providers to know what to search for. Practice improvement, effective teams. And then I showed you our echo didactics. We just started podcasts in March of 2020. I'll show you a capsule example in a minute. And then we have currents, which are sort of, if there's an article that comes out that is really high profile, we'll write a little brief commentary and circulate that as well. And that just started in August. This is an example of a capsule. We just try and have very like brief key points or key pearls that people can learn. So this is one simple step to improve medication adherence for blood pressure control. We have a key takeaway that only 50% of patients take their medicine at least 80% of the time. And then one or two things they could do about it in this paragraph, as well as links back to our website. So I thought I'd show our website Google Analytics. Sarah's familiar with some of these graphs, but we started our website in March of 2018. So you can see we didn't really have much of anything until we went live. And then when we went live, we had our first Learning Collaborative conference pretty soon after that. So we saw some increased use based probably on our registration for that through our website. And then we had our first statewide webinar later in the year where we got a little bit of an increased jump. And then we started our Echo series. And I think between the Echo series, our expanding collaborative, and our second Learning Collaborative conference, we started to get a lot more traffic. And then you can see with our subsequent Echo series, it's the month before the Echo series starts that we get a lot of traffic as people register online. And learn more about the series. And then we started our newsletter, which has our capsules and links back to the website. That started actually January of 2020. And there was some uptake after that as well. And then our podcast started sort of a month after that. So that's just, we're just tracking that to see what things we do influence the users on our website over time. So we have about 300 to 400 people using our website a month. And this just shows the unique page views. So if people go to our website, they often look at on average, 3 materials or resources. So it's not just one thing, but once they come, they're looking at multiple things. And this just shows our initial, we have a couple more podcasts since this graph was done, but our first one was with Dr. Peter Pronovost from University Hospitals. He did an outstanding initial podcast around addressing the quadruple aim in healthcare. And so that's been fantastic. And then and then since then, we've probably had about 100 people listening a month to the podcast. So those have been really outstanding. And if anybody has interest in those, there's some really great ones out there. And this is just a map of unique Ohio users. And you can see that most of the people that are using our website are within the major cities that make sense because we're linked to the 7 medical schools across Ohio, which are in those cities. And so that's where the greatest amount of use occurs. And then, but I am happy to see we're starting to spread into some of these other areas in between the cities. And I think that'll be an area we can continue to work on. So happy to see that. I won't spend a lot of time on usability, but we did assess usability of our resources, and we had 2 or 3 people review each of our documents and rate them. And so they could say that they strongly disagreed with the comments or disagreed, agreed, or strongly agreed. And in general, our median score for this, 4 is the highest. And so 3 or 4 is outstanding. And we're really pleased to see that these were generally people thought they were useful and had accurate information and would recommend them to colleagues and would change how they practice medicine. So I think there's been a lot of positive feedback. We did look at the ones that strongly disagreed or disagreed too, just to give us additional information for when we make new materials or things we might need to correct. And this is just a picture of our Learning Collaborative statewide conference that we had about 200 attendees at our last one. We had 100% of attendees would recommend the conference to a colleague where we shared best practices. And then this picture over here where everybody's showing a certificate is showing certificate of participation in our quality improvement projects. And I only have a few slides left around our quality improvement project, just to say a little bit of a brief information. But Sarah, I don't know if there's any, I just wanted to make sure there weren't any questions or comments before I move to that last piece.
Currently, the comment came in after the video saying very funny.
Oh, okay.
But no other comments or questions.
All right, great. So the hypertension quality improvement, so think about some, I only have a few slides left. So if you have anything, feel free to start adding them to the Q&A. But the Hypertension Quality Improvement Project, again, is a separate funded stream from Medicaid and is, it really looks at linking academic medical centers with Ohio primary care clinics and the Medicaid managed care plans. So that's, the medical centers are really identifying the best practices that can be used. The primary care clinics are testing, modifying, or implementing those best practices. And then the Medicaid managed care plans are really looking at addressing the non-clinical barriers to care. Our SMART aims for the hypertension project were to increase blood pressure control overall by 15%. And we really wanted to reduce disparities. So we also had an aim around improving blood pressure control among African-American populations by 20%. And our strategies were using similar to what we did in the region. We had quality improvement coaches that worked with primary care practices every month. And then we had monthly action period calls or webinars where we share best practices, we show data, so we compete on execution. So people want to compete and do better compared to their peers, but we collaborate on what is actually done and how we can make those improvements. And that's how we leverage our electronic health record data from the primary care clinics to share with them what they're doing. And then we partner with the Medicaid managed care plans, as I mentioned. And the IHI model is the Institute for Healthcare Improvement model for improvement. So they have a specific quality improvement model, and that's the one that we typically use. I'm not going to get too in the weeds on this graph. This is a control chart, and those are often used to help people show if you're improving over time for quality improvement. It's a little bit different than what you might do for a statistical improvement for using other statistical techniques, but I don't want to get too much in the weeds on that, except to just show that we did improve blood pressure control overall by 14% compared to baseline, which we were thrilled to see. This is looking at it by race, and you can see that the lighter blue line is the non-Hispanic white, and the darker blue line is the non-Hispanic Black population. And we improved similarly, we improved about 13.5% in our non-Hispanic Black population, but we had wanted to improve more. So that's an area we're continuing to focus on so we can reduce that disparity. Really eliminate it would be ideal. So in summary, cardio has grown over the last 3 years. We've successfully been able to engage with a number of key stakeholders. Our Tele-Echo series, our capsules, conferences, webinars, podcasts, and newsletters have all been effective engagement strategies. And we really, I didn't show these results, but we did find, we've asked our collaborative multiple times about how they would like to get educational materials. And it's really been interesting to see how, just different people like different learning modalities. And if any of you do education and have things to share about that with me, I'd be interested to hear if others know more about that. But I think we've found that people like different things. And so having a selection of different options is helpful. The third is improving hypertension control, and sustaining improvements is possible in diverse clinical settings, including those serving high proportions of disadvantaged populations. We used to get some feedback, well, we can't ever improve in our population because we don't have enough resources. They have all these competing demands. And so why should we even try? Sometimes I hear that sort of framework. And I think we've been able to really show that we have been able to improve blood pressure control, even in settings that have these resource challenges. So I think that's important that we still spend our time and effort improving that in primary care and continuing to work on that. And then practice facilitation in the context of collaboratives, I feel can have a really strong impact in a region or across a state. And just lastly, some future directions. We have some new focus on diabetes, as I mentioned, including a recently started diabetes quality improvement project. We're engaging with professional organizations now across the state to increase membership and reach a diverse group of healthcare professionals across the state. We have an additional focus on dissemination now that we've been developing so much content through our website. And then we have further discussions with payers outside of Medicaid that are planned. So we're meeting with the medical directors of all of the payers soon in sort of quarterly meetings to try and start engaging with them. And then we have additional quality improvement coaching that we're working on to eliminate within clinic disparities where the within clinic disparities exist. So those are some of our future directions. And I just want to take a minute before answering any questions to just acknowledge that this is a group effort. I mentioned the 123 people across the state and many others, and those are just the people paid on the grant, but many others volunteering and contributing to this work. Cardio and the QIP are funded by Ohio Department of Medicaid and administered by the Ohio Colleges of Medicine Government Resource Center. We had our regional work funded by many foundations, including Better Health Partnership. So there was a CDC REACH grant. And of course, the views expressed in this presentation are just my own and do not represent the views of the state of Ohio, of any federal Medicaid programs, the CDC, or any other funder. And a special acknowledgement to the Better Health Partnership staff, partner organization, and member clinics, and the Cardio and Quality Improvement Project team members, organizations, and clinics, because this really cannot be done without them. So with that, I will open up to any larger questions about the second half of this presentation or anything from the first half that came up.
And as a reminder, please type your questions into the Q&A, or you can use the raise hand feature to be able to unmute your mic and speak out loud. So our first question is, thank you for this talk and the very encouraging findings. Medicaid HHS pays for cardiometabolic disease management in low-income individuals, and SNAP USDA pays for food provision in low-income individuals. Because cardiometabolic disease is often caused by poor diet, could outcomes and overall government spending be further improved by encouraging HHS USDA conversation and improving diets?
Yeah, that's a great, it's a great comment. So we are, we're working with, as part of the, not part of the statewide collaborative, because we're not allowed to do policy work under the budget of Medicaid, but we certainly all have policy interests. So, I'm on this National Clinical Care Commission that's working on making recommendations to Congress, and we have a report due in September of this coming year in 2021, and that Congress is required to act on within 90 days. How they decide to act, will still be, I'm sure, different than what we necessarily recommend, but hoping that that can have some impact. So one of the things we're doing is really exploring that USDA and in the HHS sort of alignment and integration, but also not just HHS, but any of the federal agencies. So there's a number of recommendations. I'm not on the subcommittee. There's a subcommittee on general population and prevention. I'm on a different subcommittee, but that subcommittee is working on many recommendations around how to integrate around food and diet. I think that's really important. And if you have things that you want to share with me, I'm happy to, I'm sure Sarah has my email and can share that with this group, or I can actually type it in here so you can see it. But if you want to email me anything you think might be relevant, I can certainly make sure that gets incorporated. Tim, was there anything, I don't know if you'd want to unmute and share any thoughts, specific thoughts you might have on that.
You can unmute now if you'd like to, Tim.
Hi. Yeah, thanks. And thanks for that great answer. It's really, like I said, encouraging to see these improvements. I work with Darcy Friedman over at the Swetland Center, and we've seen that folks receiving SNAP have elevated levels of, I guess the best way to put it is they have elevated dietary inflammatory index, meaning their net diet produces more internal inflammation. And it's strongly associated with their SNAP use. So it started me thinking about these issues and how they might fit into the primary care context. If they're gonna pay for, if Medicaid is gonna be paying for the care, and another branch of the government is paying for food provision, we don't wanna tell people what to eat or be overly prescriptive about it, but good conversation take us to a place where diet provided by the government is promoting health more effectively.
Oh, you're on mute, Shari.
Thank you for telling me that. Any specific thoughts you guys have had about that connection, or just general, you've been thinking about that?
Yeah, I mean, I didn't know I was going to talk today, so I don't have necessarily a specific policy aim yet in place. Darcy probably could speak to this more cogently, but incentives are an option. If folks can get access to fresh fruits and vegetables, a lot of what we see in this elevated dietary inflammation may be fixable. Specific nutrients that are anti-inflammatory nutrients that are significantly lower among SNAP recipients can be addressed by just getting better access to fresh fruits and vegetables for the most part. So that's just one possible inroad.
Great. No, thanks for sharing that.
Great, thank you. So we have another question. What do you think will be successful for engaging primary care clinics in Appalachia to improve the CVD and HTN outcomes there? That one map of dark green counties versus the map of who is utilizing the Cardio website and resources was very interesting.
Yeah, no, that's a great point. We partnered with Ohio University in particular around that because they're situated within a lot of that area. And I think it's been a struggle actually to engage. We do have, like in our quality improvement project, I think for our diabetes quality improvement project that just started, I think we have maybe 2 or 3 rural clinics that are in some of that area, but it was actually a real struggle to recruit them. And part of the reason that at the time that they said that they were having challenges was that Ohio Health, which is a lot of that market in that arena, was switching electronic health records. And I think part of doing the quality improvement work is, reporting the electronic health record data and showing improvement. So I think we do need more work. We're partnering with, part of our upcoming year is to partner with the professional organizations to see if we can extend our reach through the professional organizations like the Ohio Academy of Family Physicians, which has a wide network. I think they have like 80% of the practices across the state that are family physicians. And so that's another way we can reach more of the rural networks that I think we have a meeting later this week or next week with them to start moving that process along. So I think that's how we're thinking about it now, but if others have suggestions, we are open, all ears on that. And I saw Julia's comment about there is an OU campus in Cleveland, which is true. And we have some people from OU that are in Athens, and then some people from OU that are in Cleveland that are participating on the grant. So I think that there's definitely networks even within Cleveland to reach out to rural areas. And OSU, also has sort of rural campus and rural areas too. So I think that's an area where we really want to extend more. And if people have suggestions, we'd love to hear them and be connected.
If there's any other questions or comments or thoughts, please feel free to use the raise hand feature or type into the question and answer. And while we wait for any other questions to come in, just as a reminder that our next seminar is going to be on December 9th with a presentation by Morgan Taggart on using a health equity framework to improve access to healthy food in the FAIR project. We do have a comment. Thank you again, Dr. Bolen, and it's a link in the chat box for SNAP, is it DII or data that was being referred to.
Great, I've copied it. Pasting it.
Well, if there's no other questions, thank you all again for joining us today. And thank you, Dr. Bolen, for a wonderful presentation that you gave today on the projects that you work on. And if anyone has, if you didn't get to catch the email for Dr. Bolen, please feel free to contact me responding to your registration or to the after event email that you'll be receiving tomorrow. And there's also one saying, nice job as always, wonderful work.
Thanks, Shereen. Shereen was part of this work and helped us get started and do some of those learning collaboratives. So thank you. And I know Anne is on too, who helps project direct and do all of the wonderful work that our collaborative does. So that's great.
Great. Thank you all so much. I hope everyone has a wonderful day and looking forward to seeing you all again next month at our next seminar. Thank you.
Take care.